they just had surgery, they could probably tolerate 5 or 6 minutes. Then we have to kind of lower it a little bit and do that, try to keep it there. And you might need to put a little a little weight or a rolled towel or washcloth there. So you want the toe to roll up. Again, when the leg rolls out, the tendency is just like what happened with him, is for the knee to flex. So you want to keep them in this position.
Has everybody worked on their TUI clinical either in a hospital or nursing home?
Yeah.
Probably not. Okay. Does everybody know the components of a hospital bed?
Yes.
Do you guys understand how that works? Okay. So, yeah, you guys had that over at the nursing, right?
Yes.
Okay. So, not every hospital is built the same, so they're not always going to have the knee locked out. So what that means is you could hit the incline button, their head and trunk can sit up, so they can do that to eat. They also have the foot of the bed. So when you hit the arrow to go up at TGH, the foot of the bed is locked out. Okay, so the theory is twofold. One is, if the patients are left to their own devices, they're going to assume the position of comfort, which is, like Dr. King was saying, is this flexed, open pack position. So over time, in 3 days, it could develop some shortening of that. You don't want that. Also, if it's in this position, it doesn't encourage a lot of blood flow. So you're at a slightly increased risk for a DVT. Now, if you go to work at a hospital or a nursing home and it's post-op day 3, and the patient said, well, for the first 3 days I was at TGH and they wouldn't let me raise the foot of my bed. Now they can do it. Or they go home. They can still do it. So here's what you guys have to know. If the foot of the bed comes up, or if they're at home and they have a wedge or 3 pillows, you can elevate their leg, but you have to be very careful. If the foot of the bed is raised and it's in this position, it's going to cause about a 30-degree knee flexion position. So what you have to do is you have to manually extend their knee, and then you have to put the towels or pillows like this to keep it extended. You follow me? Because if you don't do that, again, what's going to happen is they're going to be in this default position, which is a bad position for their healing. Okay? So just keep that in mind.
So that's the important. The extension and straightening is really important. You can have them go back. While we're on that, I want to keep, because there's thinking of something else. Another little tool that you can use if you have a person who is lacking full extension and they're in this heel prop position, bring that up there, and they can't get it all the way down. You can put weights, a little, 1 pound weight on their leg. They're going to have ice on it too. Where would you want to put that little weight? Why? Yes. Good. Yeah. And it used to be, like I have a patient right now, we're working on like 2 degrees. He's like 125 degrees of flexion. Only 2 weeks post-op, but he still has like 2 degrees. So we have a bag of rice that we're using right now, and we start it here. And as it gets uncomfortable, he just kind of pulls a little more in this direction, so it reduces the discomfort. So this is one thing that we can do. The other is to simply take this leg and cross your ankle over your ankle, and then do a quad set over here. And that muscle action will push this knee down passively. So this leg is relaxed, this leg does the quad set, and he can use his own weight. What we don't want to get in the habit of doing, that I will raise my hand and say I did many years ago, and I'm still amazed at myself, or what was I thinking, is to have these folks, we'd be in, I was an athletic trainer myself, we would be in like laying on them and cranking on them, and they'd be in tears and pushing you off or working on flexion. We'd be holding them down, and we'd be pulling up as far as we can, or on his belly. I mean, grown men crying doing that, and it just makes me shiver that I actually did that. Because what we know now is that patient's going to rebound back from that. You're going to cause more inflammation. They're going to come in the next day and be forced, like, okay, got to get on it better today. I mean, it was like such a Neanderthal way of thinking. So we don't do that. Patients are in control. control. More control you give them, the better they're going to do. I mean, you want them, they should not be pushing themselves to the point of two. They might be, and should be, very uncomfortable working on bending. They have got to get in this position and do this on their own as they can tolerate it throughout the day. The bending, we talked about the heel slides. Another way that we can work on the flexion exercises is, put this up here, put this back on here. They can use a belt or a towel or, not a TheraBand, but something more firm. Can you sit up? So I want you to pull it back. Good, yeah. We're going to pull that in as far as you can, and while you're doing this, of course, you could be sitting in a chair bedside to be able to measure and see what they have. They're in control. They can do it leaning all the way back, which is a real nice way to do it initially.
At the hospital, guys, I use this. I make a sling. So I put it around their foot, have them hold it, and with their arms, they can assist themselves to bend their own knee, okay?
Okay, go ahead and sit up. Come all the way, keep hold of your seat and just come all the way up. Okay, do the same thing.
Only if somebody has the flexibility to reach down and get it. You know what I'm saying by that? So they have to have pretty good hamstring flexibility to be able to reach down. But yes, some people can do that.
So again, heel slides, you can put a towel underneath so it's easier to slide if they're working on it. Again, when you're working on flexion, you don't have to go all the way back down to extension the whole time because they're working on just pulling up as far as you can. And these are kind of ways to just, what happens when you're working on motion in a joint? Folks say, gosh, I was really stiff and then I got up and I moved around and I was okay. Well, the synovial lining is what produces synovium, which is the fluid in the joint. When they sit in that open packed position, that fluid sits on the bottom, collects there, it gets really thick, and that's why it's real difficult then to get it straight. That's why you don't want them sitting like that with all that fluid hanging out there. The opposite happens when you move it. When you move the joint, the synovial lining produces synovium. That's what causes it to produce fluid. As you move it, it disperses in the joint. So the first few might be stiff. You keep moving it, disperse it in the joint, so they're a little bit easier to do. So these are all nice little warm-ups. So your ankle pumps, quad sets, glute sets, heel slides, short arc quads, you can do in hand. They can start doing some abduction without any friction, which is fine. Which approach of the hip would you not be doing hip abduction on? Direct lateral. Good. So now we're going to go to working on flexion. Okay, so we're going to have you now come up with your walker. We're going to have him get over to his chair, have his gait belt on it, come to the edge. One thing that I tell folks that are launching like the gait belt on, put your foot on the floor. Patients with after a total knee, they want to put it out in front of them and not put weight on it. Put your foot flat.
Before we get to that, can I do one thing?
Sure. Do I what? Nope.
All right.
But I don't like them at all.
No.
They never heard the word again.
And you know what? And they still use them.
Mm-hmm.
Yeah. Yeah. I'm not a, yeah. So everybody remembers what a CPM is, right? So a CPM stands for what? Continuous passive motion machine. And the theory is that by a mechanical device passively moving the knee joint, it's going to encourage blood flow, prevent DVT, it's going to start some early motion to help form that scar, prevent scar tissue. Now, I will caution you by saying that if you go into home care and the surgeon has the CPMs delivered to the house, which oftentimes they do in some surgeons, be very careful in how you set up the CPM machine, because it is absolutely crucial that when you set it up, that the fulcrum is in line with the knee joint. A lot of people don't do that, so basically it's too short or too long. So when they flex, they're flexing the wrong thing, and they become worse off. Number one. Number two, there's metal. It's a metal frame. So if the person's skin, which is inflamed to begin with, if it butts up against that frame for 3 to 4 hours, it's gonna cause pressure sore, it can cause indentation, it can cause pain, it can cause all kind of problems. So you might have to put a towel or roll something there to protect it. Okay, that's very important to realize. Also, when you're just starting out, your mind, surgeons are going to be saying you got to get the patient so many degrees, you're going to be pushing this range of motion. And before Dr. King gets to the seated position, I want to show you one thing. You can do it with heel slides like she said. Some patients will tolerate better if you hold their leg here. And so basically I'm proximal here, so I'm controlling his shin. So if I hold him like this and I let his knee come down, some people may allow gravity to help flex, okay? Here's what you want to avoid, especially within the first 7 days. You want to avoid manually putting your hand at the distal tibia and pushing this. Why?
Very painful.
Well, ACL grafts are different. In a total knee, there's not a graft per se. But in anything acute, if you really hard, if you press hard to cause that stretch force on an inflamed tissue, like Dr. King says, it can make it more inflamed. It can make it worse. So basically, how long is the stretch held for normally? 20 to 30 seconds. That's what I mean. If someone's coming back and you're holding 1, 2, 3, 4, 5, that's okay. But if you're here and you're saying, okay, let's hold this for 30 seconds, hold, it's just going to make the pain, and that just comes from years of experience and seeing the result of it. Okay.
And the time frame for how long to hold the stretch, these are acute patients and we're trying to get they have their motion, they're just guarded. So the amount of time for them to hold these versus like a tight hamstring or other muscle tightness, those are the ones, slow, prolonged, low leg stretch are the way to go. That's really, they're not going to make other patients. If you had a tight hamstring and you held it for 2 seconds, you're not going to get better. With these, holding it for a few seconds all throughout the day, because they have the motion, they're just guarded
And that's why you can do that low, long duration on the hamstring, because the incision isn't there. Sometimes it's just a capsule you're stretching, not a tight hamstring. So I mean, you can't do it in extension, but the flexion part, you gotta be careful.
So we're going to get him up and, so we've gone with our patient, we've introduced ourselves, we're going to go through some exercises, we've done ankle pump squat sets, glute sets, some heel slides, we've gone through some positioning. Now we're going to say, let's get you up and get you over the chair to work a little bit more on some bending. Okay, hands on the table, on the bed. Okay, I want you to keep your foot flat on the floor as you come up to standing. Again, they're going to want to put it out behind them. Same thing when you get over to the chair. I want you to keep both feet flat. If you need to have your right foot a little further away, that's okay. I want you to keep it flat when you go to sit. Okay, all right. Walk over to the chair. Good. Turn it back up to the chair. When you feel the chair behind your left leg, good. Now move your right foot a little bit forward so you don't put too much of an uncomfortable bend on it. Reach back down for the chair. If you would, and slowly lower yourself to the chair. And that right there is where it's going to get comfortable. Because as they start to come down, they're like, oh, I don't have that much space when I'm popping out. So make sure you have it out enough that they can do it. Because what will happen is they get used to that new knee motion, and you're also starting to get some closed chain activity at the quadricep. So we want to work with them now on some heel slides and sitting. You can use a pillowcase. These are bags that we send out to the joint replacements ahead of time, and they work really nice, but a pillowcase will do the same thing. So use a right total knee. Put your foot in the bag here. Hold on to this here. And I want you first just kind of moving your foot back and forth on the ground. Just moving back and forth.
We'll finish up this exercise, then we'll go to lunch.
Or you can have your foot in the pillowcase and using the pillowcase to pull it back. And you can do a few of these for warm up. When you start to do the actual exercise, he's only going to do 5 reps of really pushing it. Oh, no, it's
Irene, can you reach and come down? Right behind you. There's one right here, we have one.
Yeah, I brought it in.
She has a big one right here.
So you're sitting on the ground over here next to them because you're gonna be measuring out throughout the motion. So I want you to pull it back. If you've done some warm-ups here with the back, sliding it back and forth. Now this next set, I'm gonna have you do without the back so they just have another opportunity to say, lift it up. Good here? Okay. So what I want you to do is try to pull your foot back as far as you can. Let's say that's as far as you can go. That's uncomfortable. Do a good strong stretch and count. 1, 2, 3, 4, 5. Put your hands on your chair and I want you to scoot your bottom out over the foot. Scoot it up and hold it right there. 1, 2, 3, 4, 5. I lined up my goniometer, trochanter, malleolus joint line. I can see it's about 113 degrees there, and then back off. Hold for 5 seconds. All right? So breathe for a second, catch your breath, pull back a little bit more. Do a good strong stretch. Count to 5, 4, 3, 2, 1. Hands here. Scoot your bottom out. And count again. 1, 2, 3, 4, 5. About 115. So as you work through this, those numbers will increase. That second set of 5-second pull, that is you telling the patient, give it everything you got. I'm not pushing on them. You notice I'm not like, come on, come on, come on. Because they will rebound, they'll push back against me, they will hate me, and they will not do it again until I see them the next day. I want them to do this on their own all throughout the day. So they pull it back, good strong stretch. Again, pull it back as far as you can to the point of pain. Count 5, 4, 3, 2, 1, 5 times. And then get up and walk a little bit. So they're using their motion, using their knee through that newly gained range of motion. You want to tie it back into something functional. That way there will be a higher likelihood of carryover. More often, use it during function, higher likelihood of carryover. The last thing I'll show you real quick for bending is go ahead and stand up. I'm looking for the steps.
Step,
Oh, yeah, yeah. So right foot up on the step, left foot on the ground. I just want you leaning into that, knee over the toe, and back up. So now we're doing a closed chain exercise to increase knee motion. Okay, and lean into it again, good, and back. Step back a little bit with your left foot. Now again, into it. So what we're working on again, I will be down here measuring. So they're all different tools that you should have, methods that you should be able to work with your patients of how to increase both flexion and extension. After lunch, we will layer this with you guys coming up with some of your own exercise and activities to progress. This will take them through the first week. Now you need lots of other things, if you're seeing them in a nursing home or outpatient center, to work on strength and balance and motion, other exercises that we talked about to get the quads firing. And then we'll also gonna break up into groups and give each one of you an assignment, and you'll come up with your own little scenario to problem solve with our lectures today. Good?
Good.
Okay.